So for the overview, I'm going to be talking about cardiovascular diseases. I'm going to go through the assessment of the heart. I'm not really going to go too in depth into the assessment, just hit on the high stuff and some of the diseases that are related to the heart, such as MI, myocardial infarction, heart failure, hypertension, as well as their medication. I also have hyperlipidemia as well. So let's get started. So blood comes, unoxygenated blood comes from the superior and inferior vena cava into the right atrium through the tricuspid valve, and that goes to the right ventricle through the pulmonary semilunar valve to the lungs. Oxygen exchange occurs, and then blood is brought back to the left atrium through the bicuspid valve or mitral valve, and that is pulled into the left ventricle, where you see there's a lot more muscle in the left ventricle, and that is pumped out through the pulmonary semilunar valve to the rest of the body to perform to get adequate perfusion. And that is your normal heart. Next, we have assessment, and the bell of the stethoscope is you use that to hear your low tones, such as your S3, S4 diaphragm, used for your high pitches. S1 you hear with lub, and that's usually heard at the apex of the heart, and S2 you hear the dub, which is heard at the base of the stethoscope. If you hear split S2, that is abnormal. Can be normal with inspiratory, but usually it is abnormal and you would want to refer. Now for your S3 heart sounds, that is heard during heart failure, if you have heart failure, or if your patient is pregnant. And a lot of the time, that's because obviously there's excess fluid at that time, and you hear that with the Kentucky. Next is going to be your S4. And with the S4 heart sounds, you hear that with uncontrolled hypertension and left ventricular hypertrophy. So that the muscly part of your left ventricle has too much muscle. And the way you would hear that or see that in the questions would be Tennessee. So with murmurs, one thing that we see is your still murmurs, especially when they're really young. But after your grade 4 are going to be super loud, and that is associated with a thrill. And that's something that you may want to refer. So Mr. ASS is going to be your systolic murmur, pneumonic, and mitral regurgitation is heard at the apex, and it radiates to the axilla, which is the armpit. So apex, axilla, armpit, that's loud murmur, and you're using your diaphragm. Aortic stenosis, that's heard at the second intercostal space, and that radiates to your neck. And you're also using that, the diaphragm of your stethoscope. MVP, I kind of threw that in there, mitral valve prolapse, and you hear a click with the mitral valve prolapse, and that is associated with Marfan syndrome. So a great way to remember your systolic murmurs uses make a sound. Systolic make a sound which radiates. So SSR, systolic sound radiates. Again, the mitral regurgitation heard at the apex, and that radiates to the axilla, and which is the armpit. And aortic stenosis heard at the second intercostal space, that radiates to the neck. Okay, diastolic murmur, the mnemonic is Miss Art. Mitral stenosis, low pitch, heard at the apex, and then mitral regurg, high pitch, but second intercostal space, and that is a blowing sound using your diaphragm. So diastolic, I remember diastolic death or disaster or doom. And you can refer that because they're usually a little bit more complex. So let's talk about hypertension. Hypertension is one of the most common diseases related with our cardiovascular system, and it's called a silent killer because you don't really get a sign. You don't really have any symptoms. A lot of times when a patient presents to you, you ask them, "Are you feeling okay?" It's happened to me many times in the clinic. A patient's blood pressure is like skyrocketed, and I'm like, "Oh, are you feeling okay?" And I'm like, "I feel great. I feel fine." So it's really important to monitor that at every visit. And that's part of the reason why we do vitals. So what we follow for hypertension guidelines is the AHA and the ACC guidelines, as well as the JNC8 guidelines. So JNC8 guidelines are kind of being phased out, and we're kind of using the AHA and the AHA and the ACC guidelines because the guidelines are a little bit more stricter, and it's helping us to catch hypertension as we see the patient throughout their lifetime. We want to catch it earlier, prevent it before they're on medication and stuff like that. So obviously the guidelines have two-step. If it's elevated, as well as stage 1 and stage 2. So 130/80, 130/90 is kind of like the cutoff for the stage 1, and stage 2, 140/90. So medication management for hypertension, of course, the first line is going to be that lifestyle changes and modification. If your patient has elevated blood pressure, which is at 120 to 129/80, you're going to want them to, come back in the office from 3 to 6 months and repeat their blood pressure to see especially if they have a family history and they're at risk, you really want to hone in like, hey, you really have to get this under control, especially once they hit that stage 1 hypertension. That is 130/139/80/89. You really want to reassess them in about a month or about 3 to 6 months, and then consider the ASCVD guidelines to see if they are at an extra risk for that. Obviously, if they have other comorbidities like, diabetes and any other condition, that stage 1, you really want to educate the patient and bring them back in a month, 3 months, 6 months, and you may even consider, especially if they're on the higher end, starting on medication. Now, stage 2, 9 times out of 10, of course, you're going to educate them about lifestyle changes, but you really want to consider possibly putting them on a medication, especially if they've come back at 3 months, they've come back at 6 months, and they're still hitting that stage 1 or stage 2 hypertension window or hypertension category blood pressure. You don't want them to walk out of the door and have their blood pressure super high, especially as a primary care provider. So our first line medications for hypertensions, they're going to be your ACEs and our ARBs. And second is going to be thiazide diuretic, and third is going to be our calcium channel blocker. The beta blockers and spironolactone and other diuretics, those are kind of like our B team, Bravo team. So you really want to get them started on the first three, and then the other two, depending on the patient and their demographic, their history, you may or may not want to avoid them. So ACEs and ARBs. ACEs and ARBs are both working on the same system. They work approximately the same way. Your ACEs are going to be your prils, and your ARBs are going to be your sartan. But our ACEs are going to be our number one first-line medication for cardiovascular disease, hypertension. They are our heavy hitters in hypertension. So they are also cardio and renal protective, which is a plus for patients that do have renal concerns, as well as some heart issues going on. However, the caveat with the renal protective is you really have to check the patient's GFR. So risk factors for your ACEs and your ARBs. There's going to be the dry cough with the ACE. Both the ACEs or ARBs are not first line for pregnant women. ACEs and ARBs are not first line for African Americans and patients with hyperkalemia or angioedema. We are not going to start them. Obviously, there's going to be differences and caveats and stuff like that, but generally, those are our risk factors. So our ACEs are like our lisinoprils. The major concern with the ACE inhibitor is angioedema. And angioedema can actually happen at any time. But if a patient comes in with swelling or just... So with the ACEs, nausea, vomiting, facial swelling of the tongue, you want to rule out cardio angioedema, which can be detrimental. It's a severe allergic reaction to that. Our next heavy hitter is our thiazide diuretics. So HCTZ, hydrochlorothiazide, is one of the most popular medications, and it's one of the oldest medications for hypertension. And it's a kind of a soft diuretic. However, this is going to be good for African Americans, also good for patients with osteoporosis. Things that we want to really look out for, counterindications, are going to be the increase in uric acid. So this is a no-go for our gout patient. So this is also going to increase our triglycerides. So if a patient that has elevated triglycerides, we're not going to give that to them because if they have hyperlipidemia, it's just going to skyrocket that hyperlipidemia. And also, it increases your glucose. This is not good for a patient with diabetes. We also want to be careful if a patient has renal concerns. If their GFR is less than 30, that's not going to be really good for them as well. It's going to be a no-go for a patient with sulfur allergies because that can exacerbate that. I put this 12.5 to 25. That's the kind of dose we want to start with our elderly patients. And remember, with our elderly patients, we want to go low and slow for that. So for calcium channel blockers. Calcium channel blockers are good for patients that are African American, patients that have diabetes, and also is a off-label for Raynaud's phenomenon. So a patient that has Raynaud's, it's the disease that where your hands turn blue and purple and whitish when you get cold. Your cold intolerance. And so calcium channel blockers are a vasodilator. So they relax your blood system, and that's why it should be avoided in GERD. If you're having reflux issues, you don't want anything to relax. You don't want your smooth muscles to relax. Therefore, that could exacerbate your GERD, causing it to be worse. So it's going to be a no-go in patients with GERD. And calcium channel blockers are the dipine. So your amlodipine, and other medications like that. So our beta blockers are going to be our Bravo team or B team. They are not first line, but they're good for the right patient, such as pregnant women. Pregnant women have actually 3 drugs that they can use for hypertension, especially if you're getting into the preeclampsia and stuff like that. So the medications are going to be your beta blockers, such as labetalol, nifedipine, and methyl-dopa. So new little mama is a good mnemonic for that. So other patients with that are perfect for beta blockers are that post-MI and our heart failure patients. So here are some medications for beta blockers. LOL is the ending for beta blockers. So diuretics are kind of into two categories. I have here just stuff that diabetics are, your loop diuretic, your Lasix, and then your potassium sparing diuretics like spironolactones. Obviously, for the right patient, this is the right medication. Let's get into heart failure. So heart failure, there are 2 different types of heart failure. There's right-sided and left-sided. Right-sided, you have your jugular vein distension, liver concerns, enlarged spleen. Left-sided is, I remember left-sided with lung. So fluid is going to be backed up into your lungs. So you're going to hear your crackles, your wheezing, decreased breath sounds. Versus the right side, you're going to be, you're going to see that weight gain. You're going to see the edema, stuff like that. So diagnosis, obviously, your ejection fracture, normal is going to be the 55 to 70. Anything below 40 is going to be heart failure. So echo, you can do BNP, stress x-ray, and all that stuff. We as nurse practitioners don't really see patients when that acute phase, but managing them will be something that, if it's in a patient's history, something that we need to know. So signs and symptoms we want to look out for is the S3 heart sounds, weight gain. Medications that they're going to be on is going to be those ACEs, the ARBs, potassium sparing diuretics, such as spironolactone. So those are other things that those medications are used for. PAD, also known as peripheral artery disease. So patient will be presenting to you with shiny and hairless legs, and they usually have pain with activity such as walking, and it is relieved with rest. And that's also called intermittent claudication. So if a patient has some shiny legs, pain with walking, you're seeing that it's kind of just they're struggling there. you want to try and get a ABI, so atrial brachial index, and that's going to be our diagnostic. Number one risk for PAD is going to be smoking, and other things that could be happening with that patient. They can have hyperlipidemia, they can have some heart failure, they can have atherosclerosis. So a good thing that you want to do is get a couple more labs. But if they're only complaining of that stuff, of the pain with walking, do a little bit more digging and investigation. So good medications to start them on is a statin, especially if they have that high triglyceride levels, as well as aspirin. Tell them to stop smoking, and investigate some antiplatelets as well. Chronic vein insufficiency is kind of like the opposite of PAD. So your patient is going to present to you with varicose veins, brandy or brown colored thick skin, calf swelling. They're going to be edematous, so they're going to have some edema, varicose vein swelling, and they're not going to feel pain because they've got that extra fluid. And the risk factors for that is people with clots or DVTs. So while you're in office, venous Doppler, venous duplex ultrasound is going to be how you diagnose that. Medications, you're going to have, your good old-fashioned compression socks, elevate their legs above the heart, daily aspirin, walking, and you want to refer them to vascular. Let's talk about hyperlipidemia, also known as high cholesterol or high triglyceride. So high cholesterol can be common. Some signs and symptoms of hyperlipidemia is weight gain, someone that is overweight, someone that has a family history of hyperlipidemia. Hypertensive patients are at higher risk for hyperlipidemia, as well as our type 2 diabetics patients. One way that we can also find out that a patient has hyperlipidemia is at the xanthosmia. That's the lipid deposit in the eyes. So a way that we can diagnose it is through labs. HDL, those are good cholesterol. So you want that to be between 40 and 60. If it's a little higher, that's good. LDL, that's our low or bad cholesterol, and that's going to be anything below 100. Anything above 100 would be abnormal. Triglycerides, you want them below 150 or below, and then below 150, and then your total cholesterol, anything above 200 would be too much. Our number one treatment for hyperlipidemia is lifestyle modification. If a patient is overweight or is heading towards that, or trending upwards on their cholesterol, you want to tell them to do lifestyle modification, walking, changing their diet, drinking water. However, if a patient comes into the office and their lipids are super high, you want to start them on a statin as soon as possible. Good statins that we can start them, the most popular one, are the rosuvastatin, and then the parvastatin as well. Those are going to be some good statins to start with. If your patient's coming and they're slowly trending up over the years, you want to start them on a low statin. However, if your patient comes in and it's in the 800s or the 700s, you want to start them on a high statin, and then that's why I have those two different medications, and the low and the high. One thing to watch out for with statins are rhabdomyolysis. That's a breakdown of the muscles. So if a patient has any new muscles pain, that could be indicative of rhabdo. So you want to watch out for renal failure. you want to stop that medication. And these are the references that I've used for this slide deck. So we're going to skip into hematology. So let's talk about hepatitis. Hepatitis is a infection of the liver transmitted through the blood, and those are due to different agents. A is caused by fecal, so eating, food with, or people that prepare food with unwashed hands. B, blood. C, contaminants. Obviously, you can have contaminants in B as well, and blood in contaminants as well, but just keeping it simple. And D is untreated hepatitis B. So, diagnosis of hepatitis B is through a blood test. IgG is going to be hepatitis is gone. IgM is going to be immediate or active. HBsAg, if that's positive, can be acute or chronic. And positive HBsAg and a positive IgG would be a chronic. So how can you have a present infection and an infection that is gone? That means that it's been there for a while, so it's chronic. Hepatitis or HBsAg, just the S would be your surface antigen, and if that's positive, there's a virus on board. So your anti-HBs So your anti-HBs, and that's actually right here. That's what I was looking at. So if you have the anti-HBs, which is positive, that is your vaccine. Anti-HBsC, that's your core, and I have hepatitis B core antibodies right there. If that is positive, that means you have been affected, you're affected. And so if you have a positive anti-HBC, which is your core, and an anti-HBs, that means you have natural immunity. For an acute infection, you're going to have your IgM, immediate. Acute. Your core is going to be positive, as well as your HBsAg. You have an active immunity because of your IgM right here. Chronically infected, your IgM here is negative. You are not immune because your anti-HBs is negative. You have the chronic, your anti-HBC it's present. And then you're positive HBsAg. And that's positive. And so with the ear, if everything's negative, you haven't been vaccinated, you haven't been infected. I hope that helps. Really quickly want to hit on HIV. It's spread through sexually transmitted. It's sexually transmitted, or if you work in healthcare or sharing needles of any sort, that can spread HIV. Diagnosis would be your HIV-1 and HIV-2 antigen antibody immunoassay. So signs and symptoms are flu-like. And the first stage, second stage, it's going to be latent period. The third stage would be return of the flu-like. And that would be due to the increase in the viral load. So CD4 count, if it's less than 200, you are diagnosed. The patient is diagnosed with AIDS. And that's when you can start prophylactic Bactrim. And here are some quick references. Thank you very much.